49. Hi, Leah.
Hi, Kamna.
I'm very
You're
excited
home.
today. I
Wait,
am
you're
home.
home.
I am
The
home.
last time I've talked to you, you were in Florida and New York and everywhere.
So world traveling. I'm an
I
empty
guess.
nester, so I can do it.
Good
I
for
am
you.
super excited today. Are you?
I am. I can't wait. I have so many questions. Obviously, Kamna, you and I both have a ton of questions, but today we're talking to a personal friend, Dr. Kenneth Varian. He is an advanced heart failure cardiologist in Akron. And he went to Ohio State for all you Ohio State fans. And many other places as well. But would you want to start, Kamna?
Welcome. We are very happy that you could join us today. Uh, we both ask a lot of questions, so just so you're
Buckle
ready.
up.
Sounds
Buckle up.
good. Sounds
All right.
good. Yeah, I'm,
So
I'm looking forward to hearing your questions, and looking forward to seeing, what the audience, what else they would want to know if you guys ever invite me back. And of course, just short disclosure that nothing that I'm going to say here is patient care in any way, just information.
right. Hmm.
Absolutely.
Yeah.
So tell
Absolutely.
us a little bit about what you do, the type of patient you see.
Sure. So, as an advanced heart failure cardiologist, I would say about 90% of the people that I see have a diagnosis of congestive heart failure. In cardiology, it's just complicated enough that we kind of silo ourselves into different areas like electrophysiology,
Mhm.
interventional cardiology, even prevention is a separate area that some people take on, and then advanced heart failure is one of those as well. So, in terms of folks with heart disease, I'm definitely seeing them towards the end of their journey of heart disease. And so prevention is it's an interest of mine insofar that I'd prefer not to be as busy as I am and
Gotcha.
keeping
Oh,
people
yeah.
Yeah.
Yeah, that's
from developing congestive heart failure would be a lot more ideal.
Okay. So are you there? Do you feel that it is preventative?
Oh yeah, I would say that at least half, if not much more than half of all cardiovascular disease is preventable, assuming that eventually you develop something if you live long enough. So one of the things about
Hmm.
cardiovascular disease is the risk factors that we all are exposed to, whether that's blood pressure, diabetes, smoking, cholesterol that we'll talk about. It's really about the exposure to those risk factors over a long period of time. So if you make it into your 90s, I don't care how well you've taken care of yourself, you're potentially going to develop something.
Okay.
okay.
So preventable in like mid and later life, yes, most of it is pretty preventable.
So
Okay.
when you say preventable, what exactly are you speaking about?
So the risk factors that drive a lot of cardiovascular disease, not everything. There's a lot of genetics in there that I'm not referring to, and
Sure.
there's other things that I'm not specifically that you don't specifically have control over. I'm talking about blood pressure, high cholesterol, specifically LDL cholesterol, which I can go into some more detail on. Type 2 diabetes, which is not always preventable. That is largely a genetic condition, but can be very heavily mitigated through diet and exercise. Um, Risk factors also being sedentary, which means not exercising very much.
Mhm.
And then, of course,
Hmm.
the consumption of the kinds of foods that we see mostly today on the shelves, mostly processed foods, foods high in simple carbohydrates, foods that contain a lot of saturated fat. These exposure to these risk factors um, develop cardiovascular disease over time. Smoking on the list as well, although that's slowly becoming less of an issue over long periods of time. So, um, people just like invest in your 401k when you're younger to try to get dividends down the road so you can retire. Paying attention to cardiovascular prevention earlier in your life is going to pay those same dividends down the road. So you really can't wait until much later because if you expose yourselves to those risk factors when you're younger, you're more likely to develop these problems later in life.
So I had an aha moment while you were talking because, and hope this isn't offensive, but I've always just assumed like I should prevent diabetes. I don't know why, but like I've always been told like you can eat less sugar and less carbs and exercise to prevent diabetes, but there's also more to it. Like I should also be worrying about preventing heart disease as well, is what you're saying.
Yes, yeah. And type 2 diabetes, which is very, very common nowadays, is causes a lot of issues that are non-cardiovascular, neuropathy,
Right.
retinopathy, kidney disease. But in my world, it's a driver of coronary artery disease or blockages in the coronary arteries, and it's a
Oh.
driver, therefore, of congestive heart failure as well. So a big part of a big number of my patients have type 2 diabetes. Some of them not well controlled, but some of them controlled, but they've had it for so long that it's contributed to their cardiovascular disease.
Wow.
I want to dumb it down for myself. So what you're saying is genetically you could be predisposed to something, but if your environment and your lifestyle are like filled with processed foods and not moving a lot, you could trigger those diseases to come alive,
That,
basically.
yeah, that's exactly correct. It starts with a genetic predisposition. You're sort of either, you're starting a few steps behind or a few steps ahead, and then your
Mm.
lifestyle, it is diet, it is largely diet, but it's also how much aerobic exercise are you getting? Because,
Mhm.
aerobic exercise, the degree to which that can burn off sugars that
Mm.
you're eating and prevent and help with insulin sensitivity cannot be overstated. The importance of regular physical activity to cardiovascular health in every respect, but also with respect to the role that type 2 diabetes plays in it, because you can help prevent, or at the very least well control, type 2 diabetes with exercise and the appropriate diet.
Well, a
Mm.
lot of people have said, well, it's in my family. I'm going to get it anyway. Is that true?
In some, there are certainly folks that no matter how healthy they live their lives, genetically they're going to be predisposed to get type 2 diabetes. But if you have somebody who is dedicated to eating a very healthy whole food plant-based diet, we'll call it, okay,
Mm-hmm. Okay.
that's not filled with processed foods, that's low in simple carbohydrates, and they are dedicated to regular aerobic exercise, minimum of 150 minutes a week, more would be a little bit better. That person may develop type 2 diabetes, but it's going to happen much later in their life.
I
So
see.
so you may not be able to prevent it, but you're going to be able to at least very much delay it. Yeah,
Okay.
style changes.
You said 100 minimum 150 a week. That doesn't seem like a lot to me. And believe me, I don't exercise much, but that doesn't, how many is that a day if you really break it out?
It's a 30 minutes a
30
day,
minutes,
5 days a
5 days.
week. That's what
That
I tell.
doesn't seem that crazy to me.
Well, does
And
that include like a walk around your neighborhood, or does
Yeah.
that mean
it
like
does. In
sweating it? Oh,
fact, you don't
okay.
even have to get your heart rate up that high. It just needs to be in the low 100s. So a brisk walk around the
Oh,
neighborhood, but it has to be in a single setting. You can't say, well, I walked for 5 minutes there, then I walked for 5 minutes to the
Uh,
fridge, then I walked five. It has to be like, this is the 30 minutes dedicated to exercise, and that's all I'm doing.
okay,
got
what
it.
if I do, let me turn this on me for a second.
Yeah.
What if I hypothetically do 10 minutes like during a commercial break and then, oh, like, go to the store and then I come back and do 10 minutes more. You want 30 minutes straight.
Yeah, I mean, look, in my patient population, I'll take anything. Okay.
Okay.
But
Okay.
it's not like, 10 minutes is nothing and 30 minutes is everything. But,
Okay.
it's better if you can sustain the elevated heart rate for a more prolonged period of time than over 10 minutes. But look, if that's all you can do because of your life circumstances or whatever, I get that. And, nobody's perfect so I think that
Okay. All
as
right.
long
So
as you're
start
making some
somewhere.
attempt. Yes, exactly.
Okay. I like that then. All right.
Well, I would kind of actually like to talk a little bit more about the diabetes piece of this because I think it's very prevalent now and a lot more people are, it seems like to me, and I don't have the stats that probably you do, but a lot more people are suffering from diabetes or pre-diabetes and what that means for their lifestyle, for their health in general. Can you explain that a little bit?
Well, yeah, and I think while in my practice, I do very little of direct management of diabetes. I use a lot of diabetes medications that happen to also help heart failure,
Okay.
but I don't directly manage it. But I would say that the biggest things that the biggest problems with patients who have type 2 diabetes is the downstream problems that it creates in their life, particularly the development of chronic kidney disease and having to go on to dialysis. So
Mhm.
that's obviously a huge problem for a patient's quality of life, their overall health, and so forth. The development of retinopathy and not being able to see, the development of neuropathy and not being able to feel, your feet and your hands.
Mhm.
Diabetes doesn't really have a symptom unless your blood sugars are so high that you're, peeing out a bunch of sugar. It doesn't
Mhm.
really have any symptoms. It's just that over time, the excess sugar in your bloodstream is doing damage to these organs. Now, in addition, it drives the development of what we call atherosclerotic vascular disease, which is blockages in various different arteries. And that can have an effect on the heart, but it also can cause stroke, and lead
Mm.
to obviously great disability. And it can lead to heart failure later on if you develop a blockage in a coronary artery, or even in some patients, the sugar itself is toxic to the heart muscle.
I didn't
Oh,
even know that. I had
I
not
didn't
like
either.
I feel so stupid right now that I had no I just thought I knew the diabetes and what it affected. I didn't even think that it would affect your heart. I don't know
Yes,
why I
it's
didn't.
a huge. In fact, it's such a huge part of the development of heart failure and heart disease that if somebody has type 2 diabetes, we treat that patient exactly the same as if they had already had a heart attack, even though they may not have.
Oh,
So in other
wow.
words,
Really?
their risk of having a heart attack if you have type 2 diabetes is the same as if they'd already had a heart attack and you're looking at their risk of having a second heart attack.
Wow.
So it's a huge driver of cardiovascular disease.
Had no idea.
Me neither.
Wow. Wow.
Yeah, so
Okay.
it's very important to try to prevent, and it can't, even if you can't prevent it, it can be very well controlled or delayed with the lifestyle changes that we sort of talked about in not a lot of detail, but particularly the exercise, the aerobic exercise that you're trying to get 150 minutes a week of, and then the consumption of foods that are, that grow out of the ground mostly, okay,
Mm-hmm.
and that have not been processed. In the U.S., we recommend something called the Mediterranean diet. That's the diet recommended by our professional
Mhm.
societies. And you can look up online what the Mediterranean diet consists of. But if you want to keep it simple, it's mostly from vegetables, legumes, nuts, olive oil, fish, this kind of thing. Not a lot of red meat on the Mediterranean diet, not even a lot of chicken.
Really?
Not in the Mediterranean, not in the
That
pure
makes me
Mediterranean diet. I'm not
happy.
saying that
I
you
know. I
can't
know. You're
eat
enthralled over
chicken.
there.
Everything's
Connor's over
okay in
there going.
moderation. Everything is okay in moderation with the exception of like cocaine. That's not that's
Okay.
negative.
All right.
But
We'll take it.
everything's okay in moderation. But I think a lot of people think the Mediterranean diet contains a lot of pasta and stuff. It doesn't. That stuff is not included in what we're doing.
Okay.
It's a lot of things like hummus and
You
broccoli.
are you are happy, Kamna.
I am very happy. I do have I know this is sort of a side topic, but I had a question about healthy fats in relation to the heart. I think fat has gotten a bad rap. What is your opinion about this?
So I do agree with that. I think consumption of unsaturated plant-based fats can be considered generally quite healthy. Okay. I'm going to add
Okay.
one other type of fat that could be considered generally healthy, and that is fat from, quote, fatty fish. Okay. Fish like
Okay.
salmon and so forth. These types of fats are, if you were to, drip them into a bowl, they would still be a liquid the next day. As opposed
Okay.
to if drip bacon grease into a bowl, it's going to be a solid white the next day. Those are
Mm-hmm.
saturated fats,
Mm-hmm.
whereas unsaturated fats stay a liquid at room temperature. Unsaturated fats generally are not unhealthy. They don't result in cardiovascular disease. In fact, there is some science that suggests that certain types of fish oils might even improve cardiovascular health and reduce the risk of heart attack. Now, not fish oil that you buy over the counter at GNC. That actually has been tested and doesn't seem to do anything other than cause your breath to smell fishy.
And
Oh,
burps.
Yes, but purified fish oil that is being marketed under the drug name icosapent ethyl, there is some suggestion that it may help, and that's just a fat. It's fact, it's a very greasy pill that people take.
Really? Does it give you bad burps and bad breath?
Good question. I don't know the answer to that. I don't think so. Not as much
So
as fish oil does.
is that something that you have to have a prescription for?
Correct.
Oh, okay.
Yeah, and the pills are pretty big, and I don't write a ton of prescriptions for it because it's indicated for a very specific small sliver of heart patients that don't have the type of cholesterol panel that you need for this to be approved for this kind of drug.
Okay.
Plus there's some controversy over whether it actually works, but it doesn't harm anybody. That's the question.
Okay.
That type of fat doesn't harm the
Okay.
cardiovascular system. So if you're pouring olive oil, yes, that's very, quote, high in fat, but it's not going to cause the same kinds of problems as saturated fats do, like that from bacon grease, or
Mhm.
trans fats, which are sort of artificial, but it's where you take unsaturated fats and you basically make them look like saturated fats.
Okay.
what does that mean?
What's an
I don't-
example? Yeah.
Yeah.
Well, trans fats used to be used in, I think, cooking oils at like fast food restaurants. And honestly, I don't really even know the
Is that
history.
like Crisco?
Yeah, I think
Something
so.
like that?
Don't quote me on that one. I'm not actually
Okay.
sure.
Okay.
But it's
Okay.
basically taking an unsaturated fat that, from a molecule standpoint, looks like a right angle, and then it
Mhm.
makes it into a straight line. And the saturated fats are in a straight line, and so they behave very similarly. In fact, from a health standpoint, you can think of trans fats as similar to
Unsaturated.
fats as saturated.
Okay.
And
So,
saturated fat.
so good oils, including avocado oil?
Oh, good question. I have to look that one up.
Okay.
Okay.
Not sure about the avocado oil. It's a plant. That's a good start.
Yeah.
But I'd have to look to see what the
Well,
percentage in
I
saturated.
just bought potato chips that were cooked in avocado oil. So that's why I'm asking. I'm just
Okay.
making sure that I'm making sure I did an okay thing here. I'm like, oh,
Yeah,
no,
yeah.
Well,
Well,
I always tell my clients to eat avocado oil, so I'm curious on that one too. I'll have
yeah,
to
we'll have to
look
look
it
that
up.
one up, or I'll have to look that one up. And remember, everything's okay in moderation.
right.
Mhm.
I don't tell people
Exactly.
they can't. There's something that they absolutely can't do. Yeah.
Right. Good. I like that too.
I want to
So,
go backwards a little bit if it's okay. You said something about medications that help with diabetes and the cardiovascular health.
Yes.
What?
So there's two classes of medications that are both helpful for heart health and also type 2 diabetes. And there's an interesting piece of history that people might find interesting that plays into this. So back in 2008, there was a drug called rosiglitazone. I actually forget the brand name. I don't really think much in brand names. In fact, sometimes I have to look the brand name up. But this rosiglitazone medication was a diabetes medication, and it was pretty good for diabetes. It really helped. But we found out that it actually increased patients' risk for having heart attacks. So what the FDA did is they said to the drug makers, if you're going to come out with a new diabetes drug, you can't just prove that it helps the blood sugars. It also has to be shown to be safe for the heart. So what
okay.
that forced the drug companies to do is run these large clinical trials where they trialed their new diabetes medication versus a placebo and make sure that it didn't hurt the heart. Well, in 2015, there was a trial done on a drug called empagliflozin, which goes by the trade name Jardiance. And this medication was okay for diabetes. It wasn't the greatest diabetes medication, but it worked okay. But interestingly, the patients that got that medication had fewer episodes of heart failure, and they died at a much lower rate from cardiovascular disease compared to the patients that got placebo. And what that showed us is that it wasn't just that empagliflozin was safe for the heart. It was also that it actually improved the heart in some way. And what empagliflozin does is different than any other medication. And now there's a bunch of them. There's dapagliflozin, sotagliflozin. There's a whole bunch of different medications that do the same thing. It tricks the kidneys into making you pee out sugar. You pee out about a candy bar's worth of sugar per day.
Wow.
And into the kidney.
Wow.
Yep. And so the idea
Wait.
was, go ahead. Yep.
Dumb question. Does your urine smell sweet?
Yes.
Really? Okay, sorry, go on.
I
No,
would not
it's
have thought
yeah.
of that.
So the idea was, okay, you pee out the sugar, blood sugar goes down, and that helps the diabetes. Well, it turns out that when you do that, the kidneys become protected. And for some reason, there is a shift in the way the heart metabolizes like nutrients, and it tricks the body into thinking that it's in like a starvation mode. And what rises in the blood is something called ketones, similar to if you were to go on the so-called ketone diet.
Keto, yeah.
So it's sort of like going on a ketone diet. People lose about 6 pounds on the medication on average, but it's not really that effective for weight loss overall because 6
Okay.
pounds is much. But it seems to have a very important effect for the heart. So what does it do? It helps protect patients with kidney disease. It helps the diabetes, and it helps heart failure to a significant degree. And so I'm using it for, you can almost find an indication in almost any patient that shows up in my office for the medication because the indications are so wide. And there are some health nuts out there that are using the medication off label because they think that it does promote longevity, although we don't have data for that in healthy people.
Is this a different, sorry.
No, I was just going to say it only prolongs longevity in patients with heart failure and those with chronic kidney disease.
Because their life expectancy would have been shorter without the medication. Is that correct? Okay.
Correct.
Is this a different medication than the ones we've been hearing about all over the media, the Ozempic and the Wegovy and the Manjaro?
It is a different set of medications. Those medications, the GLP-1 receptor agonists, we call them the glucagon like protein receptor agonists. These medications have been around for about 20 years. The very first one was called exenatide, and it was an injection for type 2 diabetes. And it was pretty effective at lowering blood sugars. And there were several other examples of medications that came along that did very similar things. Liraglutide, dulaglutide, semaglutide, which is Ozempic, tirzepatide, which is Manjaro. And those are the two that we talk about the most nowadays. And we always knew that in type 2 diabetics, it did promote some degree of weight loss, but it was never used in patients that simply had a problem with their weight.
Okay.
In other words, like there's a lot of type 2 diabetes patients that don't really have, an issue with their body mass index or BMI. And while they did lose a little bit of weight, this stuff wasn't tracked that closely. So several years back, the companies decided to trial semaglutide or semaglutide, depending on how you want to pronounce it, which is also known as Ozempic, in patients that were just overweight. They didn't have type 2 diabetes. They were just overweight. So this is another example of using a type 2 diabetes medication in patients that don't have diabetes, which seems a little off. And what they found is about a 15% drop in their body weight over the course of a year.
That's a good amount, 15%.
Imagine if you weigh 300 pounds, that's 45 pounds of weight loss.
In a year, yeah.
In a year, exactly. So very significant. And while this data has been around for a while, it's really hard to get it approved by insurance just for weight loss. But a lot of my type 2 diabetes patients that are overweight benefit from it in that way. Is this how I wish they all would lose weight? Of course not.
Right.
I wish everybody would follow the perfect Mediterranean diet and only buy food on the outside of the grocery store instead of the inside where the things that are that are in boxes and cans exist. Okay. But the reality is that the world that we live in is the cardiovascular disease affects people of lower socioeconomic status predominantly, not completely, but disproportionately anyway. And it's hard to afford some of the foods that I recommend. And,
Mhm.
I can bang my head up against a wall or try to do something about this. And so,
Mhm.
I do have started using semaglutide or Ozempic in patients that have issues with weight, but also have cardiovascular disease, because nobody comes to me just for a weight problem.
Right. Right.
Um, Wegovy is semaglutide that's just packaged in a higher dose. There's no difference between the two medications. So Wegovy,
Okay.
they
Okay.
tell Wegovy and Ozempic as being different, but they're not. They're the same thing.
Okay.
Um, Semaglutide was then trialed in patients that were overweight but had a history of having a heart attack. So these were patients that, they were overweight, but they didn't have type 2 diabetes, but they did have a history of a heart attack. And what they found is a very significant reduction of the risk of having a heart attack in the future. And that sort of changed things for us, because then as a cardiologist, now we're looking at this and saying, well, now it's no longer a diabetes medication. I just need to find someone that's had a heart attack that's overweight. And in my world, that's basically everybody.
Mhm.
And
Right.
they're potentially going to benefit from this medication. So the uses of these medications is going to significantly explode soon because of that. And they do
Wow.
have side effects. There's a small risk of having pancreatitis, and there's a small risk of having a bowel obstruction, but they're generally pretty safe. And of course, what I tell people when they're reluctant to start them, I say, listen, if you can do this with diet and exercise, my God, please do it.
Mhm.
If you can lose 50 pounds with diet and exercise and get your diabetes under good control and your blood pressure under good control, please, I will take all these medications away. But if you can't do that, then we have to come up with plan B. And that's what this
Mhm.
is.
So
Mhm.
you were talking a little bit about the side effects. I'd like to just for a minute explore that a little bit more, because I think it's important for people to understand. Obviously, you have the good like cardiac health, better like with weight loss comes a lot of other benefits
Mhm.
to your organs and general health. But what about some of the negative side effects that we've been hearing about?
Yeah, so the main side effect of these medications is abdominal pain and nausea,
Mhm.
particularly when you eat.
Okay.
Honestly, that's probably how it works in some ways. Okay.
Oh.
If you're sitting there having a meal and you typically eat the full plate, and you get halfway through the plate and you suddenly feel very full, that next bite is going to make you a little on the nauseous side. And this is how the medications achieve weight loss. It's not magic. People are just eating less. And so the side effect
Mm.
of feeling full earlier, feeling a little nauseous when you eat, feeling a little abdominal pain, I would say it occurs in the majority of people, not the minority.
Okay.
So, if you look at the trials on these medications where they were trialed against placebo, there's 40% reports of nausea with the use of these medications, especially when you reach the higher doses. In fact, the way we titrate it is we titrate up to the nauseous side effect, and then we come down in the dose a little bit.
Okay.
So what is the mechanics of building up the dosage, and then do you leave it at that high level or do you decrease it? How does that work?
Usually, and full disclosure, I'm involved only peripherally in the titrations because there's
Okay.
20 hours in the day, and I have my pharmacists do that. I mean, medicine is definitely a team sport. And
Mhm.
but what they are doing is they're increasing the dose, trying to get, if it's semaglutide, it would be 2.4 milligrams per week as an injection. Tirzepatide, which is another one that I use, which is Manjaro, which is actually more effective at weight loss. We titrate that one up similarly, but at different doses. Once you reach a dose that is either at 2.4 milligrams or the highest tolerated dose, which is the dose where they have a little bit of discomfort that they don't like, then you come down a little bit and then you leave them there if it's effective at curtailing their appetite.
So when you say nausea, is it all day nausea? Like when I was pregnant and I wanted to just lay in bed all day?
No, it's mostly nausea associated with food.
Oh, okay. Okay.
Yeah. I mean, you can kind of tell when you're having a meal with someone that's on the medications, because they'll be eating and then all of a sudden they'll stop and they'll say, "Oh, I'm done." And they'll push it away.
Mm.
And if they know when to stop, the side effect doesn't come on as much. But the
Okay.
other side effects that are more rare, like bowel obstructions and pancreatitis, exist. And those are risks that, you have to weigh against the risks, the benefits in the patient's, given
Right.
situation. And you have
Right.
to remember that I'm not seeing that patient who does not have type 2 diabetes, whose heart is normal, and they're just looking to lose some weight because they're upset about their weight. That person doesn't come to see me. I don't know what I would do with that person if they did come to see me. I would be reluctant, I think, at first to prescribe the medication without like a full attempt at lifestyle modifications first. I'm usually using them because like these people are much more advanced. They have the issue with the weight, but that weight has developed into coronary artery disease and now heart
Hmm.
failure and chronic kidney disease. So it's like a little more of an emergency, you
Right.
know, and
Right.
we want to get those risks down instead of,
Yeah.
around. I should also mention that before prescribing one of these medications, I always, if the patient's BMI is high enough, I always offer them referral to the weight loss clinic for bariatric surgery consideration first.
Oh, really? Okay.
And the reason is because I don't know what I'm going to do with these people in 5 years on this medication. How am I going to get them off of it?
Oh.
It's not really a permanent fix, right? Unless their habits have completely changed with respect to their eating habits, and they're never going to go back to the way they ate before. There's nothing to stop from the weight going back on when they come off the medication.
Mm.
Wow.
And
That's
we
a
don't
really
really
Yeah.
know for sure because these medications are too new for these current uses to know what will happen to the weight. But there's some suggestions in some studies that weight gain does happen when you come off of them.
Oh, really?
Yeah. Unless you have a full diet and lifestyle change.
Correct. Unless you've gotten so used to these portions that you're okay just eating these portions and this type of food and that kind of thing.
Mm.
Wow. Okay, I know this may not be in your scope, but I have a really weird question. So
That's
we
okay.
hear about like Ozempic face and Ozempic butt. Is this a real thing?
That's a great question. I have no idea.
Okay.
Okay.
I've not heard of that. Ozempic face. I don't
I've,
know.
s- I will, this is very judgmental of me, and I'm just going to be honest. I've seen people on social media, and I'm like,
Yeah.
oh, their face looks like,
I've
I
heard it
mean, their
described
weight
like a
loss looks
zombie.
great.
Yeah. I don't know. I mean, it depends, I suppose, on where you're losing the weight, right?
Yeah.
Um, and it's not really known exactly where you predominantly lose weight with Ozempic, but it's probably the case that you're losing mostly weight that's like actually intra-abdominal and like
Hmm.
around the organs, and not so much in the face, although yeah, you have to excuse me. I don't I don't really get on Facebook anymore, so I don't really know what's
Well,
on
I
the
had a
social
feeling
media.
this was beyond your scope because if you're looking at heart health, you're not really, this is not
Yeah.
a question for you,
But
but I thought maybe you would know.
I think it's what people are saying because they want to be on it, but they don't want to be on it. Do you know what I
Right.
mean? So they're like, well, I don't want to get that anyway. Do you know
Mhm.
what I mean? I
Yeah,
think
yeah, no,
that's how the
sure.
rumor started.
I think that, if you're in this, if somebody's listening out there that does not have heart disease, but is overweight, they've tried everything and they're adamant they don't want to go for bariatric surgery, or maybe their BMI is not high enough for bariatric surgery, then
Okay.
this is a very reasonable option. But I think it should be accompanied with this is to get me there so
Mhm.
that exercise is easier for me.
Oh,
And,
okay.
this is so that I, can get myself there. So I'm feeling good about myself. So I can change my diet and then I'll wean myself off of it in a year or two. It's very expensive too. So if it's not covered by your insurance, out of pocket costs about $1,200 a month.
Yeah.
Wow.
So
So it would be covered if you had some cardiac risk or diabetes or,
yeah, definitely type 2 diabetes is easy to get it covered. If it's just for cardiovascular disease and being overweight, the data on this is within the past few months, not it's
okay.
very recent. And so insurance companies usually take a couple years to come around to
Oh,
covering things that that we just learned were effective.
Mhm.
Hmm.
Wow. This is fascinating.
I'm like soaking it in right now because I'm just intrigued by the fact that it helps. Well, first of all, that it's been around for 20 years and nobody hears about it. First of all, like, so
Mhm.
it's pretty much safe, correct?
Well, it's definitely safe from the perspective, I guess it's safe from the perspective that it's it's hitting a receptor that's natural. It's mimicking a natural hormone in the body. Okay.
Okay.
It's safe in the sense that it's not going to, the risks of developing, for example, pancreatic cancer, which is one of the extremely small risks. The vast majority of people that go on these drugs are going to do fine with them.
Okay.
And if they're going on with the right indication, they're going to do a lot better.
Mm-hmm.
They're going to have a higher
Right.
quality of life. There's great, and this is I'm speaking specifically about the heart failure patients right now, but a higher quality of life in the heart failure patients and those with cardiovascular disease. Now, why is that? It's probably associated with the weight loss. People feel better,
Right.
not carrying around as much weight. But these are not patients that got on the drug, and because they got the drug, they're saying they feel better. They were injecting themselves, and half of them were getting just salt water. So they had no
Mm-hmm.
idea what they were actually putting in themselves. And they're saying, I'm feeling better, more so in those that got the drug. So yeah,
Yeah.
it's been around for a while,
Hmm.
uh but for this indication and the expanding indications, it's just more recent that it's sort of exited the
Interesting.
realm of just medicine, and now it's sort
Yeah.
of the popular culture. So
Hmm.
But I mean, a lot of medications start out like that, right? They start out in
Mhm.
one arena and then they see that it helps for something else. So then they market it for the second purpose.
Of course, I
Right.
mean, well, how do you think they discovered Viagra?
That's
That's
what I
what
was
my
exactly I was
mom
thinking
told
of.
me. I don't want to know why my mom knew that, but my mom has always told me that. Yeah. Yeah.
That also started out for something heart related, wasn't it?
Blood pressure, and we still use it
Oh,
for high blood pressure in the lungs, not in the body, but in the lungs. That's a different
oh, okay.
conversation.
All right.
So I do use
High
it
blood.
for that purpose in my patients. But when they were trialing it, you have to write down side effects, and the number one side effect was I'm having a lot more sex. So
Big
If you could
problem.
consider that a side effect for some
right,
people, I
right.
guess.
So then they took
Wow.
that. So.
Interesting.
Well, I know
Okay.
you guys wanted to talk about cholesterol, so let me talk a
Mhm.
little bit about cholesterol, and I'll see where this takes us in terms of questions. Okay.
Okay.
So cholesterol is a lipid, which means it's like a fat, and like any other fat, if you drop it in water, it's going to form these like little pods of grease. Okay. And because of that, you can't just put cholesterol in the blood, or it'll form these grease balls and it would never be able to circulate. So cholesterol gets covered in the blood with something called a lipoprotein, which is just a protein that the body creates to be like the envelope for the cholesterol, to sort of hide it from the blood so that it doesn't develop into these like grease drops, basically.
Okay.
So in the realm of cholesterol, there are different types of lipoproteins. Some are really dense, and we call those high density lipoproteins, or HDLs,
Okay.
or lower dense, and we call those low density lipoproteins, or LDLs.
Okay.
LDLs are the bad ones, and LDL cholesterol is known to sort of make its way into the walls of the arteries. And there, the cholesterol that's in the walls of the arteries can be eaten up by immune cells. And this can cause blockages and inflammation in the blood vessel walls that can lead to heart attack and stroke down the road.
Okay.
So the LDL cholesterol is what we want to be as low as possible. Now, is that the only thing that matters? No, it's just one of several things. You know, are you living a sedentary lifestyle? Are you smoking? How's your blood pressure? Do you have a family history of heart disease otherwise? Do you have type 2
Mm-hmm.
diabetes? All of these things play a role. Cholesterol just happens to be one of the modifiable things that we can do we can fix with diet and medications.
Okay.
We used to call HDL the good cholesterol, but we don't call it that anymore. And the reason is not because it's bad, but because we don't think it's good or bad.
Mhm.
Oh,
HDL, or the good cholesterol being high, is a marker of lower risk. So having a high HDL is better. But artificially raising HDL with a medication does not help things out at all.
Okay.
So high HDL is associated with exercise, healthy living otherwise, genetics. But raising it with a pill such as niacin doesn't do anything. So we don't think about the HDL anymore. Although we use it in some of our risk calculations, we don't do anything with it purposefully.
Okay.
So LDL is what we want to lower to as low as possible. And their goal for LDL cholesterol lowering depends on your age and what's going on in your life, otherwise, with the other health conditions. And so even though it would be great if people had almost no LDL cholesterol all the time, we don't, give 5-year-olds pills to lower their cholesterol, even though
Right.
maybe it would be beneficial, but it would be beneficial in 80 years. And we don't do that kind of thing. We focus on a little bit more of a shorter term time horizon, like about 10 years.
Mm-hmm.
Reason we know that LDL cholesterol is bad is that everything that we've ever done to lower it has helped. And there are some families out there with genetic mutations in which they are able to clear LDL cholesterol from the bloodstream into the liver much faster. And those folks, and they have, LDL cholesterols in the, 10, 20 range, much lower than the average. And we always wondered if there was something wrong with them. But there isn't, other than the fact that they live a long time and none of them ever have heart attacks or strokes. So we know that getting that LDL cholesterol down as low as possible is healthy. Now, there's not a ton that you can do dietary wise to make this happen, or even exercise wise. Now, if you go on a whole food plant-based diet, is your LDL cholesterol going to get better? Yes, but perhaps not low enough for people with really high cholesterol to get it to where they want it. Nevertheless, independent of the cholesterol, the a person that lives that healthy life with lots of exercise and the healthy diet is going to do better regardless of how much they lower that LDL cholesterol.
so
Mhm.
I just want some clarity. You're saying that the LDL is the one we want to focus on, and for some people who are at a very high level, they need medication to lower that number. That lifestyle won't be as impactful. Is that correct?
It will be impactful for their overall risk, but
Mhm.
it will be incompletely helpful if the LDL cholesterol doesn't reduce. So in other words, like the healthy living is going to help everything. It's going to help the blood pressure. It's going to help
Mhm.
the inflammation. It's
Mhm.
going to help all this stuff that doesn't matter for the LDL cholesterol, but it will also help the LDL cholesterol. So in other words, what I tell people is you're never going to get let's say that I have somebody, I'll give you an example, that's young and their LDL cholesterol is 200. Well, that person should be treated with a medication. And that's because I know in their 40s or 50s, they're going to end up having a problem someday. And they'll say, I
Um,
want to do this with diet and exercise. I'm like, do it with diet and exercise, but also do it with this medication.
So if they lower it with the medication and lifestyle, can they get off of the medication?
They can, if that's they can, but let's say that somebody's LDL cholesterol is 100, 200, and with diet and exercise, they get it down to 160. Technically, they could come off the medication as long as their LDL cholesterol didn't bounce back up to 200. I would tell that person, that's fine. I'm not sure what you're trying to achieve here by coming off the medication, other than just the feeling of not taking a pill.
mhm.
Because the medication is still going to lower your risk, and you're going to be better off having taken it. But if somebody does lower it and they want to come off the medication, I mean, I'm an adult doctor. It's a free country. People can do
Yeah.
whatever.
Right.
I just provide advice. But
Yeah.
there's in the realm of the cholesterol medications, particularly the statins, they've been shown to be very, very effective and very safe. And so, you know, most most people that have to go on it at one time, I tell them that if they're doing okay on it, they're better off staying on.
Okay,
Mm,
that makes sense.
mhm.
I do want to know, and maybe this is just a artifactal information.
Mhm.
It seems to me that women, as they approach perimenopausal and menopausal age, seem to suddenly have a spike in cholesterol. Is this something that's true, or is it just
Well, they have
anecdotal?
a spike. They definitely have a spike in their overall risk for cardiovascular disease. So women's risk is pretty low premenopausal, regardless of what's going on. Now, there's exceptions to that. Type 2 diabetes and heavy smoking will negate any, risk,
Mhm.
reduction of being premenopausal. But once menopause comes along, their risk will increase to just under that of a man's risk.
Okay.
Exactly what it does to the cholesterol itself, I'd have to look up to see what the most recent papers are on that. I don't think that women's cholesterol increases too much at the time of menopause, but definitely cardiovascular risk, which is the most important thing to think about, does increase at that time.
Really? Okay.
I
Hmm.
was listening to some other podcast, and they were talking about how cholesterol isn't necessarily the marker for a problem, but it could also be they need to look at inflammation and, like you were talking about, diabetes and lifestyle and all those things. Can you speak to that inflammation piece, or is this?
I can. Yeah. So that point you made is correct. That inflammation at the end of the day is probably the driver of the blockages developing in the arteries from the cholesterol. So if you think about the cholesterol going into the walls, it's not going to do anything until the immune cells attack it. And then at that point, that's when the problems develop with respect to developing these blockages. Now that inflammation we know is there because we have tools to measure it using a test called a C-reactive protein test, or a CRP. And what we've been able to show is that if you reduce that inflammation with various different ways, obviously lifestyle. Go ahead, Leah.
When you say inflammation, do you mean inflammation in your heart or inflammation in your joints or
In the
what do you
walls of the
where?
arteries,
Okay. All
inflammation
right.
in the walls of the arteries. It's not like inflammation you can feel. It's
Okay.
inflammation that is only detectable on a blood test, but it's
Okay.
there acting as sort of like an underlying oven that is causing the arteries to become blocked up over long periods of time. Now,
Okay.
the this inflammation, if you knock it down with a medication that just goes after inflammation, does not go after the cholesterol at all, you can lower someone's risk of having a heart attack. Now, the trouble
Wow.
is that our tools for that are limited. And we do know the statin medications reduce inflammation significantly. So usually that's enough. So if you can, but there are studies that have shown that if you give somebody a statin medication, their LDL cholesterol comes down, but they still have residual inflammation left over. If you give them a medication to reduce that inflammation, their risk of having a heart attack goes down even further.
Wow.
And so, but that's a tough one because we don't have the best of treatments. There's a medication called colchicine, which we use for gout. That medication can reduce your risk of heart attack, but it hasn't caught on in the United States. You can only give somebody so many pills, right, before they start to look at you.
Right.
And there's a medication that was used a few years ago that is used in some types of inflammatory diseases. They trialed in heart patients and it worked, but it's way too expensive and the risk reduction is too low for it to cut off.
So how do I know if I have inflammation in my heart?
Well, we can send CRP and blood tests to look for that. Do I do that routinely? I don't.
Yeah.
Um, the reason is in part because I would probably do that if my practice was predominantly prevention. Like if people were, like
Okay.
if healthy people were coming to me saying, I want to do everything in my power. I'm already, jogging 5 days a week. Look at my diet. I want to live forever. Tell me what I can do to live forever. So then I'd probably say, okay, well, let's drive your LDL cholesterol down to, nothing. And then we've done that. Okay,
Okay.
what else can I do? Oh, I guess I can look to see if you have elevated
Okay.
CRP, in your
So
blood.
that's not when I go get a routine physical, they're not ordering that test
No,
for me.
no. Some years ago, when the CRP test was developed, there was talk about whether we were going to check this in everybody. Um, and there is some science to support the notion of checking the inflammatory marker, and then if it's high, even after treating their LDL cholesterol, then you can add something else. But it's for reasons I can't fully explain. I think the benefits were just low enough that the juice wasn't quite worth the squeeze for it to catch on widely.
Right.
But you
Right.
still see it done in some specialized prevention clinics.
Hmm.
So, and if somebody
Fascinating.
asked me to do it, like if they came in with like a paper and said, "Can you check this?" I would do it for them. I wouldn't know
Yeah.
exactly what I would tell them. This is the only thing that's going to happen is it's going to lead to another pill. Uh,
Right.
are you willing to take that pill before I go down this road?
Mm.
And in right now, the data would push me to prescribe colchicine if the gout medication, if for residual inflammation, if I found it to be high
Mm.
and the patient was up for quote doing everything.
Right.
So if I come to you as a patient seeking prevention because I have a medical history or, genetically I'm predisposed, it, I, I'm going to try to see if I can sum up what you're saying. Because it seems like they're all connected, is that we have to change our lifestyle. We have to move our bodies and we have to eat better. Is that, obviously that there's more to it, but if I don't have the medical issues right now and I'm looking to have a longer, healthier quality of life.
Yes. So, and I'm speaking to the 90% of people out there that don't have some unusual genetic predisposition to a heart condition for which their lifestyle has no impact. There are
Okay.
examples, and I could talk about those all day, but that's not, since that's outside of your control, it's a little bit less important to talk about. But in my clinic, I don't have a lot of people that talk about the half marathons they used to run. I don't have a lot of
Mm.
people that talk about the plates of vegetables that they eat. That's the people that I see are people that they live the lives we see everybody live in the United States.
Right.
You know,
Mhm.
and it's not a knock on anybody that's doing that. I certainly my diet is far from perfect. I
Mhm.
don't practice everything I preach. I try, but it's hard. I
Mhm.
think I had some processed foods today for lunch. I think definitely had a cookie. That wasn't healthy, but so I get it. I get it. When people tell me that's very hard to do, but if your goal is to not be my patient, if you move and
Mhm.
you know foods that are grew out of the ground and weren't processed mostly, and
Mhm.
eat meat, it's fish.
Mhm.
And if you stay a healthy weight, I'm probably not going to get to know you, which is good.
Mhm.
Well,
You don't
no
want to
offense,
get,
but I don't
oh,
want to.
Yeah.
no,
Yeah. Right.
you definitely don't.
Interesting. Hmm. Does the Mediterranean diet have dairy on it?
Oh, I knew you were going to ask me that, and
Good
I didn't have
question.
time to look it up because I was thinking to
I
myself,
just
"Oh,
was
they're going to ask me
thinking of
that."
that too. I was like,
It
oh,
doesn't, I don't think.
I don't think it does either.
Southern Italy, I don't think has many cows, uh, but I think that again, going back to when people talk about dairy, moderation, right?
Okay.
I think if you're the kind of person that is not lactose intolerant and you can tolerate a little bit of dairy,
Hmm.
I have Chobani yogurt every morning. It's got a lot of protein in it. That's the reason
Yeah.
I'm eating it.
Yeah.
Calories, 80 calories.
Yeah.
Uh, but it's a little processed and it probably has some things that's got some more sugar in it that probably I should be eating. But
Hmm.
you can't be
It's better
perfect.
than a donut,
Right. Exactly.
right? Okay.
Definitely.
All right.
This has
Well,
been fascinating, and I know Leah and I could ask you a million more questions.
I know. By the way, I have questions that my mom wanted to know too. So we might have to have you come on again.
Definitely.
Okay, well, I'd love to. What do you think you guys would want to talk about in the future?
Blood
Um,
pressure.
Oh yeah, we could do that. We could talk about
wait,
that for a long time.
I want to know about low blood pressure too. Is that bad?
No,
What if it's really low?
I mean, are you able to stand up
Yeah, I'm standing
without
up.
passing out? Then you're okay.
Yeah. All right, good. All right, that's about it. No, I'm sure there's more with that, but yeah.
No, I mean, you remember you're talking to a heart failure cardiologist, so most of my patients have a blood pressure of like 80 over 50. So, and
Okay.
that's by design. It's a little bit, but a lot of them have blood pressures in the 80s to 90s.
Mhm.
And, you know, a lot of not just patients, but also doctors freak out about that. But I tell them the same thing. As long as you can stand and you don't feel lightheaded, you're okay.
Okay.
And
All
the
right.
first thing that's going to be angry if your blood pressure really is too low is your kidneys. Now, I'm not saying that people with low blood pressure should have their kidneys monitored. I don't think that's a thing. But that would be if your kidney function is okay, you certainly don't have to worry about blood pressure being too low. I mean, it's healthy. Normal
Okay.
blood pressure. So we talk about blood pressure 120 over 80 being normal, but it's probably not true. It's probably much lower than that is normal. And it's just higher because of our diets and our lifestyle and our stress in our lives.
Okay.
I am probably another topic that I would like to understand, and maybe again, this is out of your scope, but you talked about the kidneys, you talked about the heart, you talked about liver. What systemically, like how do general medical things affect at least those three organs? And what can
Mm.
we do to really increase the health of our organs long term?
So we could
So
talk
that,
about the liver for a while.
yeah.
Um, the other organs, kidneys, it's all about blood pressure control and diabetes control.
Mhm.
Lungs, it's about not smoking. Um, the liver, though, lately, meaning in the past, couple of decades, there has been this new condition that has become very prevalent called non-alcoholic steatohepatitis or non-alcoholic fatty liver disease.
Mhm.
Yeah, I've
And it
heard of
is
that. Yeah.
derived from basically type 2 diabetes and dietary problems. And it's
Mm.
actually one of the number one reasons why people need a liver transplant. It's bad. And
Hmm.
it comes from this phenomenon called visceral, meaning intra-abdominal or around the organs fat. And visceral fat is bad. And one of the things we could talk about is that your heart health is not really correlated very well with your weight. In fact, you might have noticed that I did not mention weight once when I was talking about the
Mhm.
various different risk factors for cardiovascular
Hmm.
disease. Now, extreme obesity can cause heart failure, but that's a different conversation. But where you keep your weight is plays a huge role in whether or not
Um,
that weight will be an important factor in whether you're going to develop heart disease. So if you are one of these folks that keep your weight down in your hips, you might not like that because of the way it makes you feel when you're walking around, but it's probably not going to cause any heart problems.
Okay.
But if you keep all of your weight up here in the chest and the abdomen, that's like an oven of inflammation in there. And getting rid of that intra-abdominal fat is probably in part how some of these medications like the Jardiance medication I mentioned earlier and the Ozempic, that's probably in part how they work is by getting rid of intra-abdominal fat
hmm.
and reducing the inflammation that occurs from that fat. And then the intra-abdominal fat around the liver plays a big role in deterioration of liver function over time.
We could still, we have
I
to
know.
have you on for more questions because
Yes.
you're a wealth of information, you're very knowledgeable, and you make it very easy to understand, which is, I think, important for the average person.
Hmm.
Well, thank you very much. And I know that we have to
Hmm.
conclude here. But why don't you guys write down some of the stuff that you want to know about and send it to me, or if there's if any of the listeners type in any topics that they want to see covered, we could see if we can talk about that
Awesome.
stuff.
That would be awesome. Awesome.
Thank you
Thank you
so much.
so much. Thank you, Kenny.
No, you're very
Really
welcome. Very
appreciate
welcome.
you being on. You're not at home, are you?
No, I'm in my office.
Hmm.
Yeah. I don't have anything on the wall.
Okay.
It's just renovated. So.
Gotcha. So